Hello and welcome to Virtual Face to Face with Dr. Bruce Jarrell. I'm Alex Lakowski, Executive Director of Media Relations. On today's program, it's the most frequently and most urgently asked question in every part of the world and in every language. When will we have a vaccine against COVID-19? It's a critical question since many experts say the pandemic may not be halted until a significant majority of the world's population gains immunity, one way or the other. A few months ago, the conventional answer to the question when might have been a few years from now or maybe never. But as the number of coronavirus victims around the world surges, now well past 4 million, so too does the number of research teams preparing and testing vaccine candidates at a record pace. More than 100 vaccine candidates are at some stage of development. A dozen are already in clinical trials or will be in the next month or so. One of the leaders, under the development by a team at Oxford University, is already in phase 2 trials, and the team there says a vaccine could be ready by fall. A week ago today, Cambridge-based Mrna Therapeutics announced that it received FDA Fast Track designation for its vaccine candidate, calling phase 2 trials imminent, with planning underway for a phase 3 trial as early as this summer. Also last week, UMB's Center for Vaccine Development and Global Health made another major announcement as the CVD became the first in the U.S. to begin testing 4 variations of a COVID-19 vaccine candidate developed by Pfizer and Germany-based BioNTech. Like the Moderna candidate, these candidates use messenger RNA rather than an inactivated piece of the actual virus to spark an immune system response and the production of antibodies to fight the virus. Joining Dr. Jarrell to talk about this and other developments is Dr. Kathleen Neuzil, the Myron M. Levine Professor in Vaccinology and Director of the Center for Vaccine Development and Global Health in the School of Medicine. I should note, too, that in recognition of her expertise and leadership in vaccinology, in 2019, Dr. Neuzil was named a member of the World Health Organization's Strategic Advisory Group of Experts on Immunization, or SAGE, the WHO's principal advisory group for vaccines and immunization. Welcome, Dr. Neuzil.
Thank you.
Before we begin, let me just say this program is being recorded and will be posted on our COVID-19 website, umaryland.edu/coronavirus. A little later in the program, you, the audience, will have a chance to ask your questions or make comments. Here's how you do that. Look for the tools at the bottom of your screen. They're all enclosed in circles. Click on the button with the speech bubble to open up the chat function. If you're using a cell phone, now that button may be on the upper right-hand area of your screen. Type your question there. When the time comes, we may call on you to ask your question. So please listen for your name and be ready to speak up. I'll do my best to give you a heads up by sending you a chat message in return. So please look out for that too. Now, with all that out of the way, here's our host, UMB Interim President, Dr. Bruce Jarrell.
Thank you, Alex, for that wonderful introduction of Dr. Neuzil. We are indeed very fortunate to have her in our midst, an expert in this area of vaccinology. And so what I'll do is get right down to the brass tacks here. Dr. Neuzil, I think I'll call you Kathy if that's okay. Tell us the answer to this question. When will we have a vaccine? And tell us a little bit about that trial that you're doing.
Yeah, if I answer right away, nobody will stay on the full hour, right? So, of course, the answer is we don't know. But as was alluded to, I think we're working in an unprecedented time here where the first phase 1 in the United States, for example, which was the Moderna mRNA vaccine. And while we weren't testing it here, there were certainly members of CVD and the University of Maryland School of Medicine who were involved in the design of that trial. You know, that trial went into phase 1 within 2 months of having the virus sequenced. So while it seems slow to all of us who are anxious to get back to our regular activities, again, these timelines are unprecedented. You heard a bit about the Oxford vaccine, and they're moving quickly from, phase 1, we usually vaccinate dozens of people, and then phase 2, we go to hundreds of people, and then phase 3, we usually go to thousands. And those timelines are being compressed. And we even have manufacturers who, at risk, before they know their vaccine works, are starting to make large quantities of this vaccine. We may see vaccine by the end of 2020. If we do, it will likely be limited quantities, and there are many advisory bodies right now thinking, if there are limited quantities, what makes sense, who should we vaccinate first. We need more than one manufacturer to supply the 325 million people in the US, the 8 billion people in the world. We really would love to see 3 to 4 vaccines, on the market by the first half of 2021 to really be able to supply the world.
Hey, Kathy, why are manufacturers taking this big risk of manufacturing before they know? Seems like a big bet.
So it is a big risk. I mean, one reason is we're clearly in an unprecedented pandemic that's causing morbidity, mortality, economic disruption. The other is that many of these manufacturers have help from us, the taxpayers, with public-private partnerships. So this risk is actually being mitigated with government funds to allow them to move more quickly, to start manufacturing before they know exactly if their vaccines will be efficacious.
Right, and we are going faster than usual. I think everybody has said. Is there a trade-off of going rapidly relative to safety?
Yeah, and that's a good question, and a lot of people are asking that question. You'll see that the first types of vaccines that are going into clinical trials are vaccines that we've used before. So for example, this mRNA vaccine from Moderna, which was the first vaccine to go into clinical trials in the US, a very similar product had been tested for influenza and for Zika. So we're taking that spike protein on the SARS-CoV-2 that everybody's heard about and inserting that into a vaccine and formulation that's already been tested. Likewise, some of the other vaccine candidates, Sanofi, who's the largest manufacturer of influenza vaccine in the world, is using a recombinant process for a COVID-19 vaccine that's very similar to their influenza vaccine. So that's one way that we're getting in faster. The other way is that even though we're moving faster, it's still being done in a very deliberate, controlled way. So we're starting with the healthiest participants, for example, in these trials. We're following them very closely. The FDA is looking closely. At the same time, a lot of the animal studies that would ordinarily be finished ahead of time are continuing in parallel. So you will see while we've made it into phase 1 quickly, we will have almost the same data to go into phase 2, so that phase where we're going into hundreds, as we ordinarily do.
Right. Now, this vaccine that you're trialing is somewhat of a new approach with the messenger RNA. Could you sort of explain to us why is that different? Is it better? Is it known? And what do you expect out of your trial?
Yeah, so the mRNA vaccines, ordinarily when we get vaccines, we either get a weak live virus vaccine, and that's what measles is. It's a weakened or attenuated virus. Mumps, rubella are the same. Or we get a protein vaccine, or maybe a piece of a bacteria or virus. So, hepatitis B is simply the surface antigen. So it's a protein vaccine. Most influenza vaccines are protein vaccines. So where this differs is rather than giving that spike protein, the SARS-CoV-2 spike protein, we're instead injecting the sequence, the genetic code for that, and then our own cells are making that protein. This has a few theoretical advantages. Again, whether this actually leads to licensure and efficacy is yet to be known. But one advantage is that these can simply be made faster. As I said, they're not made in a biologic, they're not made in cells. We know the sequence of the virus and very quickly can formulate this. They're in a lipid envelope, and then that's what's injected. So the manufacturing is faster, the scale up is faster, and potentially, if you can scale up faster, you can make more doses and potentially at less cost. The other advantage is your body is seeing this more as a virus would be seen. That's what happens. The viruses get into our cells, they take over our machinery, and then our cells make the virus. And so if your body is seeing it in the same way, then the idea is that perhaps the immune response will be better or more appropriate for a vaccine given in this way. Again, yet to be proven, but that's the theory behind using these vaccines.
And with this vaccination, it's an injection or is it inhaled? How are you doing your trial?
Yeah, so it's an injection. So again, it's a messenger RNA wrapped in a lipid, intramuscular into the deltoid muscle. So the way that many vaccines are given, what that lipid envelope does is it helps it get into the cell, because remember, we have to get into the cytoplasm to then be able to use the cell's ribosomes and to decode the message and make the protein. So yes, it's an injection, and then that's the idea. I mean, we believe within about 6 to 12 hours of the injection, the vaccine actually gets into your cells and then begins to make the protein.
So the method of delivery, in other words, not through the respiratory or the GI tract, doesn't seem to make a difference. You can give it injectable and get the same effect.
Correct.
Yes. So a couple of questions about flu. So we all know that you get a different seasonal flu shot every year. We know that the flu vaccine or the flu virus seems to be able to change from year to year. What are the odds that that's going to happen in this virus?
Yeah, that's a really good question. I think people are aware that there are seasonal coronaviruses that cause the common cold. There are about 4 of them that we recognize pretty regularly, again, that cause fairly mild upper respiratory illness. We've had in the last 20 years 3 introductions and outbreaks of more severe coronaviruses. So the original SARS that was in the early 2000s, and then something called MERS, Middle Eastern Respiratory Syndrome virus, which is transmitted directly from camels to people. And then, of course, this current SARS-CoV-2 virus. We are following it very carefully from a genetic basis. What we've seen with these other viruses, again, is it's been a new introduction of the virus, probably from a zoonotic source, an animal source, a bat source, and not that there's been evolution of these viruses, at least in the past. So again, there may be mild sequence changes. I would say it's unlikely that this will be major. It's a different virus than influenza. But I will also say we've only known about this virus for less than 6 months. So we're learning a lot about this particular virus, and that will be one of the aspects that we follow very carefully.
Right. Okay. And there must be something, the spike protein. Is it the spike protein that makes this virus so dangerous for humans, particularly with hypertension and diabetes? Can you give us some insight as to what's making this virus so vicious?
I'm not sure if I can entirely answer that question. Again, I think we're starting to get clues about it. It's clearly a respiratory virus. It enters through the respiratory tract, and it causes, an acute febrile respiratory illness with cough, with dyspnea, with sore throat. However, it absolutely has systemic manifestations, and we're recognizing more and more those systemic manifestations. One aspect that we're beginning to understand is this ACE receptor. So, influenza virus infects and it binds to a sialic acid receptor. So in this case, coronavirus infects and binds to an ACE receptor. You may have heard one of these unusual manifestations, which is loss of taste or smell, and we believe that is because receptors are present, in the nose, are present in those areas that the virus binds to. So we know that there are direct viral effects. And we know from a study done here that was led by Dr. Justin Ortiz, Dr. Karen Kotloff as part of a multi-center trial, that an antiviral remdesivir can shorten the course of this illness and decrease mortality. So we know that there are direct viral effects because an antiviral works. However, we also believe that there are likely is an inflammatory component to what we're seeing, an aberrant immune response component to some of these characteristics that we're seeing with this virus, whether it's an exuberant immune response, whether it's the microemboli we're seeing, the Kawasaki's like disease in children. I think there are a lot of aspects of this that we don't entirely understand, and it's going to likely be, as many diseases are, a combination between the direct viral effects and the immune response to that pathogen.
Right. So I know I can't ask you to think back to the epidemic of 1918, but undoubtedly you've read about that epidemic and know something about it. So one, what are the similarities between that and what we're seeing here? And two, what do you know about the post-recovery or the recovery phase of that epidemic? How long did it take? What kinds of recrudescences or reoccurrences occurred? What's sort of your thinking about the comparison between then and now?
Yeah, so as somebody who knows a lot more about influenza than coronavirus, I appreciate you pivoting to something I feel a lot more comfortable with. But most of us in the influenza field, have talked about 1918 and been preparing for 1918 our entire careers. And I believe it's actually one reason why we are positioned so well to respond to coronavirus. The investment in influenza vaccines, new types of influenza vaccines, new types of manufacturing has certainly positioned us better than it would. Some similarities that aren't necessarily good similarities, back in 1918, we actually did not know what caused that disease. We knew later in 1933 is when we first isolated the influenza virus. So it was thought to be a virus and it had classic manifestations.
Wow.
But at the time of that pandemic, we did not have the ability to identify or diagnose the virus. Now later, people went back to samples in formaldehyde that the Department of Defense has. You may have heard of this very famous expedition to Alaska where they exhumed some bodies that had been in permafrost, and we were able to prove with PCR and molecular techniques that in fact it was an H1N1 influenza virus. But at the time, nobody knew that. At the time, we had no antivirals and no vaccine. So in some ways, I'm very sorry to say, it's very similar to today. And while a new pandemic virus, influenza virus strain would have been very difficult and we would have not had a vaccine right away, we would have likely had effective antivirals. So back in 1918, if you look back at the pictures, what they had to offer were these non-pharmaceutical, non-specific measures. You'll see pictures of people wearing masks. You'll see that mass gatherings were stopped, that church was stopped, that, schools were closed. And so, it's hard to believe that more than 100 years later, that those are our responses. They're very appropriate responses, but again, you would have thought that medically and scientifically we might have more to offer right now, but it's a brand new virus. The other thing that we saw in 1918, and you're hearing this now on the news as we start to loosen some of these restrictions, that we still need to be careful. Because as we saw in 1918, there were 3 waves of this virus as it spread. And so, you had a peak and then it declined and then a second peak and a third peak. And in fact, for influenza, it started in the spring and then the largest peak was the next fall. Influenza and coronavirus are not the same virus. We know that influenza virus does have a strong seasonality. You know, it thrives in the winter, in periods of low humidity and cooler temperatures. We don't know that about coronavirus, but we know that there are still the vast majority of the population is immune. We see how easily this virus spreads. I think we have to be prepared, certainly, for continued transmission and continued outbreak.
Right. So we had a chance for some pandemics in the past decade, didn't we? We had Ebola, we had Zika, we had a number of other viruses. So what do you think it was about those viruses, which are obviously very lethal? Why didn't they get a foothold and become a pandemic? What's sort of the difference in the medicine or the dynamics of this?
Yeah, so I think with Ebola and Zika, again, those are both very severe diseases. Ebola certainly has a very high fatality rate. If you get Ebola, you are quite likely to die from Ebola. But they spread in much different ways. So, you know, Zika has a transmission pattern that relies on a mosquito, so an insect vector. Ebola takes a blood contact. So here we have a virus that's much more easily transmissible. And when we talk about influenza viruses and the characteristics that make it a pandemic, you know, some of these apply to Ebola and Zika, but some of them do not. One is you need an immune population. And we saw this with Zika, right? When it would be introduced into an island situation, for example, it would be a new susceptible population, but very quickly, enough of the population would become immune that then the virus would wane. You have to have a virus or a pathogen that causes disease, right? I mean, if something is transmitting, but the disease is trivial, we're not going to worry about it that much. And then the real key that makes this coronavirus, the SARS-CoV-2, so different is the ease of transmission. So again, Ebola is deadly, but difficult to transmit. You know, coronavirus, you may have seen the recent article, it made the lay news and the MMWR about the choir practice in Washington State, you know, where attack rates are 60 to 80%. So for every choir member, you know, every 10 choir members that were there, you know, more than 6 got the disease. So you have a disease that we believe is spread through the respiratory route. Maybe it's also spread through other routes. We're not quite sure yet, and we're learning. But again, it's much, much easier to transmit than those other viruses that you mentioned.
Right. So Alex says we have a whole lot of questions for you from the audience, and we have quite an audience here. So Alex, why don't you start off with your first question?
Well, we do have a lot of questions. I guess the first one will be the first up. That's Ira Allen. Ira, are you there?
Yes.
Go ahead.
Well, actually, I have the first question that I asked you over the chat was about just being able to be involved in as a participant in vaccine studies, and that was a little bit more of a personal question. I'm interested in doing that. But before you get to that, let me ask a question that's been on my mind a little bit more recently. I listened to I can't remember his name. He's in the public health department at the University of Maryland, who does a lot of research with aerodynamics, and he gave a discussion about the way the virus is transmitted in enclosed spaces, like the choir in Washington State. I'm in Washington State, and also studies of restaurants where infectivity was shown to be in parts of the restaurant and not in others. I'm curious what the thought is regarding transmissibility outdoors versus indoors. It seems to me intuitively that outdoor activities with good distancing, with the changeover of airflow rapidly in the environment, in the atmosphere, would lead to a lot less risk of infectivity. I'm just curious what the thoughts are about that.
Yeah, so, you know, full disclosure, I can't say. It may have been Don Milton, who we work with, who's done a lot of studies on influenza transmission at the University of Maryland College Park. I'm not sure if that's the expert you're referring to. he is truly an expert in virus transmission, and maybe I'm a bit of a pretender, but I will give you the best answer that I can. You know, we do know that there are these super spreading events. We saw them with the original SARS. So that means people who can infect a lot of people. And you're right, it generally has occurred in more closed spaces. Although if it occurred in more open spaces, I think it would be harder to epidemiologically put together. But regardless, you've heard about, you know, the 6-foot rule and the mask, you know, to minimize secretions, to minimize rejection if we cough, etc. So yes, it does make sense to me that if you're outside, that transmission would be less likely. There are a few caveats that others have raised. You know, if you're jogging, for example, and there's a lot of deep breathing or heavy breathing or whatever it might be, that might change the equation. Smoke, air pollution, you know, there are aspects that might change the equation in ways that we don't completely understand. But you can also see where outbreaks are occurring, right? They're occurring in jails, they're occurring in long-term care facilities, they're occurring on cruise ships. I mean, that was one of the first places we recognized this. So clearly, when you bring many people together indoors, this is what we're seeing.
Alex, next question. Oh, wait a minute. One thing. How do they enter into trials? That was the question.
Oh, how do they enter into a trial? So go to the University of Maryland. Is this all internal? University of Maryland people, go to our CVD website. Perhaps, you know, even during this call, we could put it up on the screen. So we have a page that says volunteers check here. You know, right now we have a post-exposure prophylaxis study going and a vaccine study going. As we have more studies, they will all be added to that webpage.
Okay, Alex, next question.
All right, Eileen Berry is next, and I really hope she's on the line because her question is one I probably wouldn't know how to ask correctly. Eileen, are you there?
Yes.
Oh, go ahead.
Kathy, I'm wondering with this vaccine trial that you're doing, I know safety is the primary endpoint, but are you looking for, in terms of immunology, an ELISA titer to a particular antigen, or is there a neutralization assay available?
Yeah, so Eileen, really good question. Eileen works with me. I was hoping she wouldn't make me look bad, but very good question. So yes, absolutely. So primarily with phase 1, you go into small numbers, as you've said, for safety. But we are looking at the immune response, and it is a dose escalation trial. So we start with the smallest doses, and then we increase. So we're looking at both. So as you know, ELISAs tell us that there's some antibody there, but we don't know the function of that antibody. A neutralizing assay, actually, you take the virus, you know, and you mix it with the serum sample, and you see if the antibodies can actually neutralize the virus, so keep the virus from growing. And Eileen, I know you know this, but everybody in the audience might not know this. So absolutely, we are doing for all of the clinical trials, the neutralization assay is the gold standard. As you might guess, this is quite difficult to do because you are actually dealing with the live virus. So it's done in BSL-3 conditions. You know, it really takes a lot of expertise to be able to do these assays safely. You know, Dr. Matt Freeman here in the Department of Microbiology is one of the few people in the country now with the ability to do these assays. We're having to expand very quickly because obviously these academic labs can't possibly handle the volume that will come with all of these trials. And so the manufacturers are beginning to develop these assays. And then we're looking to see if we can bridge. So if the neutralization assay, which is the gold standard, aligns with easier assays, whether it's an ELISA or, you know, what we call pseudo-nude assays, or there are other types of assays we can do that you can do in a faster and safer way, then we will pivot to those. But for now, Eileen, they are using the neutralizing assays as the gold standard.
Thank you. Alex, next.
See what I mean? It was good that she asked that question. Sam M is next. Sam, do you have your mic open? Are you there? Sam M. All right, I'm going to ask Sam's question. This one I get. He says, if the mRNA method is trying to replicate the virus, how is this different from actually getting the virus from another person? Will the immune response be less severe?
So good question. Again, unlike we're a little bit of a disadvantage with this virus when we're trying to develop and manufacture influenza vaccines or malaria vaccines or cholera vaccines. These are diseases that we've studied for a very long time. We understand what natural infection looks like. We understand what development of immunity looks like. Here we don't. So we're basically learning both at the same time. We're learning how a vaccine works and induces an immune response at the same time that we're learning if a person is infected, what natural antibody would you develop and what immune response would you develop. So what's become a very valuable commodity is something called, acute and convalescent sera. So people who get SARS-CoV-2, we get their blood several weeks after they've recovered from the infection. We look at their antibodies. We look at some of the antibodies that Dr. Berry brought up, neutralizing assays. And these are what are being used as positive controls and standards for the assays that we're using in these vaccine trials. What we don't know is, what level of immune response will be protective in the long run, even in the short run. So we're learning as we go the similarity between the immune responses in natural infection versus vaccine-induced immune response.
Great, thank you. Alex, our next question.
All right, David Engel has our next question. David.
Hi, thanks for taking my question. Hi, Kathy and Dr. Jarrell. As a non-scientist, I was wondering, what is the relationship between treatments for the disease and vaccines from a research perspective? Are they completely parallel, or is there somehow a relationship? Thank you.
Yeah. So what's happening right now, and what should be happening right now, is we are trying to do everything we can as fast as we can. So, you have an entire spectrum. You've heard a lot of people say to really have a handle and change the course and trajectory of this pandemic. Yes, we can continue to stay at home. We can continue to test and trace and isolate. But to be able to resume normal lives, we're really going to need an effective vaccine that prevents the disease. Now, drugs can also play a role. So they're different, but they're on a parallel track. So we might use drugs in two ways. So you heard me mention the remdesivir trial. And remdesivir is actually a drug that was used against Ebola. Because similar to vaccines, normal drug development times could take years. And so what scientists, I've already mentioned Dr. Freeman, what scientists such as Dr. Freeman are doing is they're saying, what are drugs that already work for some of these other diseases that might also work, which means they're already licensed, that they might also work for COVID-19 disease. And then that way we can get them into testing very quickly. So Dr. Freeman and others in the US are testing these drugs in the laboratory against this virus. And when those tests look promising, then we're doing controlled trials. So the remdesivir study that I mentioned is a trial that was done to look at if you already have the disease, can we improve the course of that disease, right? Can we shorten the number of days you spend in the hospital? Can we keep a moderate disease from becoming severe? And then the other way that drugs may be used is actually to try to prevent the infection. So I had mentioned influenza and some of the antivirals. If I get influenza, I can take a pill that will shorten the amount of time that I have flu, and I won't feel quite as bad as I did if I didn't take that drug. But the other thing that we can do is if I'm working in a nursing home and there's an outbreak, I can give that flu drug to everybody in the nursing home to keep them from getting flu. Now, it's not the same as a vaccine, because if I get a vaccine, I make my own antibody response and it protects me for a period of time. If I take a drug to keep me from getting a disease, it only works as long as that drug is in my system. So if I stop taking the drug, then it stops working. But this actually allows me to mention another study when Dr. Jarrell asked me about the study. So Dr. Miriam Laufer here at the University of Maryland School of Medicine is an expert in malaria and using a drug called hydroxychloroquine to prevent malaria. So any of you that have traveled know that this is exactly how we use this drug. That, I take a drug, it may be hydroxychloroquine, it may be other anti-malarial drugs to keep me from getting malaria. So in Dr. Matt Freeman's lab and in other labs, we've seen that hydroxychloroquine can actually work against the SARS-CoV-2 virus. So what Dr. Laufer is doing is when somebody is diagnosed with COVID, we are reaching out to their close contact to see that if we can treat them as soon as possible after that contact. So if my husband were to have COVID, then if I could get hydroxychloroquine as early as possible, it could prevent me from getting symptoms of the disease or prevent me from getting severe disease. So we're doing this randomized trial where if people have been exposed to either a healthcare worker, again, somebody in a household, perhaps somebody who was driving in a car with someone for several hours, then we're doing all of this remotely. We're doing a telehealth visit to make sure they look fine and they're healthy, and we review all their medications and their symptoms. Then we randomize them to either receive hydroxychloroquine or high-dose vitamin C. We have a courier send that to their house. They take that every day. They fill out a diary every day. They swab their nose for us every day, and then we send a courier to pick that up and come back. So we are trying to see if medicines not only work to treat a disease, but if given early after exposure, if they could keep someone from getting sick with the disease.
Thank you. Thank you, David. What we got next, Alex?
Well, Kelly O'Connell would like to ask her question, but for technical reasons, I'm going to ask it for her. She writes, can you please explain further how our cells make the spike protein, how that results in immunity? I thought our immunity from SARS-CoV-2 is a result of our response to the spike protein rather than creation of the spike protein, but clearly I'm missing something. Can you explain?
No, I actually think you've got it, and I probably didn't explain it well to the beginning. So if I get the virus, and that spike protein is the protein that, again, attaches to the receptors in our respiratory tract and elsewhere, then, it gets into our body and it starts to replicate, then yes, our immune system responds to that, makes specific antibody, and we know that some of that antibody is to the spike protein. So then if we were to see that spike protein again, right, the antibody would attach to the spike protein. The spike protein would never be able to attach to our cells, or if it's ongoing, wouldn't be able to attach to more cells in the body, and we limit the infection. So what's happening here is that we're giving that mRNA, and our cells are making the spike protein, and then the sequence is the same. Our body sees the spike protein, our body makes antibody to the spike protein. And then if we're exposed to the real virus, we already have the antibody to the spike protein without having to go through an infection and an illness. It binds it, then the virus can't bind to our cells, and it keeps us from getting sick.
Great. Alex?
All right, we have James Bow. James, are you there? James, you can ask your question, or I'll ask it for you. Well, James writes, he says, the stay-at-home order will be lifted Friday evening by Maryland Governor Larry Hogan. What should we do next, and what would be best for UMB?
Yeah, so again, maybe I let Dr. Jarrell answer this one. And Bruce, I will let you say something about it. In general, and I think people know that Dr. David Marcosi, Dr. Wilbur Chen, both faculty members here in the School of Medicine, have been advising Governor Hogan and have been considering all of these aspects very carefully. You know, we know that there's always a trade-off. We know that elective procedures have been put off. We know, very unfortunately, that children are not going in for their routine vaccinations, even though they should be. We know that, you know, other health outcomes really depend on us being able to get out into society safely. We know the economy is devastated. So this is all a balance. So yes, Governor Hogan is reducing some restrictions, but again, this idea of social distancing, we still don't want to go out if we don't have to go out. You know, a meeting like this that we can have by Zoom, there's no reason for us all to crowd into an auditorium. We should be staying home as much as we can. Businesses that open are being encouraged to be at, you know, 50% or less capacity. People that can telework should keep teleworking. I have a whole wardrobe now of, you know, different color masks here. Here's my prop. We should be wearing masks whenever we are around anyone and out in public. So yes, this is gradual, but the threat is still there. The virus is still there. So we're having to do this in a deliberate and very careful way. And Bruce, maybe you can comment on specifically how the campus is looking at this.
So we have an elaborate process that's informed by a lot of expertise on this campus to advise us as to what can we start doing safely and what can we not start doing safely. And I think in a general hierarchical fashion, what I would say is high priorities to increase. And when I say increase, I don't mean turn the switch from off to on. I mean gradually increase, getting people back in their basic science labs. We have had some basic science taking place, but it's been largely limited to COVID type research. We also think it's very important to get into the clinical research mode, and we have been in clinical research mode for COVID, but I will tell you that again, as Kathy said, there's a balance. Well, there's a balance there too, because you don't want a clinical trial to interfere with the clinical care of a sick patient. On the other hand, we need to learn what's going on if we're going to keep other sick patients alive. So we've got to balance those things. And the third thing that I would say needs to move forward, but again, in a very considered and careful manner, is, after all, what's the essence of UMB? The essence is that we have students and faculty taking care of patients. We have attorneys and social workers working with clients for social justice, and getting back in that mode of thinking, and again, some restrained manner, is a high priority. So I expect to see us loosen up, but slowly, over the summer for those priorities. We'll have to look carefully around end of June, somewhere around there, as to how many other kinds of activities, such as classrooms. I don't think you're going to see large classrooms, but you might, people in large classrooms, but you might see a few people in classrooms, or you might see some small group situations. So I think my answer is we're trying to be very thoughtful about that. The same as I just mentioned about student and education, but the same is true about teleworking and the like there. As we loosen up, it'll be slow, it'll be deliberate, and it'll be considering each person's individual circumstances relative to childcare, relative to transportation, relative to all the things like that. So there will be a lot more coming out. In fact, there'll be a release tomorrow about the overall sort of way we're approaching this and what principles we're following. Okay, Alex?
Okay, Ashley S. has a question about a controversy that's gotten a fair amount of media attention lately. Ashley, are you there?
Yes. Hi, Dr. Nutzel. Hi, Dr. Jarrell. I just wanted to know your thoughts. Dr. Nutzel, I know you had a flu human challenge trial. Do you suspect that, if approved, CVD would participate in such a trial for COVID-19?
Yeah, so I appreciate you asking the question about COVID-19 challenge study. So for those of you who may not be aware, human challenge studies or controlled human infection models is when we intentionally give a pathogen to a healthy volunteer. And we may do this for a number of reasons. We may do it to understand the disease. We may do it to understand immunity. Most of the time, we're doing it as a way to test vaccines and antivirals. And there has been a real grassroots effort in this country and around the world to say that if we had a human challenge model, so if we intentionally infected people with SARS-CoV-2, then we could learn about this disease and we could test vaccines more quickly. Just so you know, Dr. Mike Levine here, Dr. Karen Koffloff, Wilbur Chen, Matt Lawrence, we are one of the leaders in the world at doing human challenge studies for other diseases. So malaria, cholera, we did an influenza challenge study this past fall, Shigella. So we know very well how to do challenge studies. I am part of a group that's actually evaluating this and writing a commentary about this. I am not ready to do a SARS-CoV human challenge study, and I think for a number of reasons. We don't have what's called a rescue therapy. If somebody were to get sick from this, what are we going to do? We have an intravenous antiviral that works okay, but there was still 8% mortality in the group that received the antiviral. So again, unlike malaria, influenza, cholera, for which we have treatment, we don't yet have a treatment. The other aspect is I don't think we understand the disease well enough. For those other diseases, we know that generally young, healthy people don't get as sick. We don't quite know that yet. We know that statistically they don't get it as sick, but young, healthy people are certainly dying from this disease and getting sick. So what I and others are advocating for is a parallel approach, let's start thinking about challenge models. They're actually very difficult to develop. Let's start thinking about what strain we would use. Let's get community input. This would have to be done in BSL-3 conditions. We'd have to have very tight infection control and monitoring. We'd have to work with the health department because, again, this could be released or spread to the community if we didn't have the right engineering control. So we at CVD are not prepared to do that yet. If, an effective, easily tolerated oral therapy becomes available, if we can more definitively understand who gets sick and who doesn't and who would it be safe to do this in, then we could potentially change our minds. But again, I'm speaking for myself right now. I think we have plenty of COVID in the community. We can learn, we can do these studies in the usual way that we do them, and we don't need to do human challenge studies.
And so you just heard a description of highly ethical, responsible research. And of course, people ask these questions, and this is where IRBs, but it's also where responsible principal investigators are very thoughtful about what's safe and what isn't. And I think you just heard a very good answer to that. So thank you for that answer, Kathy. Alex, what else do we have?
Oh, we have many, many questions. Here's James Evans. James, are you there?
Yes, Alex, I am.
Go ahead.
To Dr. Newsom and Dr. Jarrell, when we get a vaccine, what do you think would be the best way to distribute that vaccine across the population?
Yeah, so that's really an excellent question. And there are certainly, as you might guess, you heard I'm on the WHO stage, which is the Vaccine Policy Committee for WHO. Here in the US, we have the CDC, ACIP Advisory Committee on Immunization Practices. These groups, even without having a vaccine, are already starting to think through these different scenarios. If you had X amount of vaccine, how would you use it if you had X times 2 amount of vaccine, how would you use it? Part of it will depend on the type of vaccine. You know, we're seeing older people get sicker from this disease, but we also know certain vaccines don't work as well in older people. So there will be both a generic approach, but some of this could be specific to the vaccine. I think some of the groups that are coming to the top of the list are the groups that we see during similar exercises for pandemic influenza. You know, in 2009, I actually led the national advisory body that made decisions on how we use the scarce resource of the pandemic influenza vaccine. You know, not surprisingly, it's frequently healthcare workers and first responders that come to the top of the list. There's nobody to take care of COVID-19 patients, of course, if we don't have a healthy healthcare worker task force. And similarly, other vital workers that we're seeing in the community now who have been indispensable during the last few months. So again, these are very early discussions. I'm not saying in any way that these decisions have been made. It'll depend on the characteristics of the vaccine. It'll depend on how much vaccine we have. And it will depend partially on what we learn between now and then in terms of who the highest risk groups are.
Yeah, and the only thing I would add is there will also be humanitarian efforts in this area, just like we've seen with HIV and the intense activity in other countries. It's in our interest as citizens of the world to make sure we manage those areas as well, or help manage them. So I wouldn't forget that one either. Alex, what else do you have?
Well, as you might imagine, we have more than a few scientists in the audience. Here's Judith Britz. Judith, you there?
I'm here. Can you hear me?
Yes, absolutely. Go ahead.
So, Dr. Neusel, you talked about various ways of assessing the efficacy of vaccines using antibody neutralization or ELISA titers. What about assays for T-cell immunity? What kind of tests are you doing to explore vaccine efficacy of T-cells?
Yeah, so that's a really good question. And again, you're getting on the fringe of my expertise. I rely on many of my brilliant colleagues in CVD to help me there. I can tell you on the current clinical trial, the primary measures of immunogenicity are absolutely antibody. But we are collecting, these volunteers are very generous. They're generous with their time, and they're generous with how many times they allow us to draw their blood and to get specimens. We're actually not in these early clinical trials looking at any mucosal immunity. We will have some cellular measures, but at the moment, what we're doing is isolating cells, and those have not been completely decided because, as you might guess, those are somewhat precious samples. We want to have a better understanding of the disease. We want to see what comes out of animal models, and then there will probably be some sort of, committee or consensus panel that decides how to use these precious specimens. So the antibody assays are fully defined in the trials with the FDA, and right now the cell-mediated immunity assays have not yet been decided.
But let me make a related comment, and that is that I've now had the pleasure of participating in at least 4 CVD vaccine trials. I originally did that because I wanted to see how well the machine worked. I can assure you that it works extremely well, and it's very impressive. And I guess I would urge all of you, whether it's this trial or some other trial, to be aware of some of the very well thought out and important studies going on at UMB and get involved in one way or another. I've survived it, I'm happy to say.
You've thrived.
Well, you can't have an IRB that approves research and then say, but not for me. Okay, you have to be, I think, cognizant of if we're saying this is safe for people, we're people, we need to participate too. It's an important statement. Alex, what else do you have?
Well, if the question of when we'll have a vaccine is number one, I think number two is probably the question that Jana Kaplan-Fastow has. Jana, are you there? she is. Jana? I'm going to unmute her again. Jana, go ahead. Oh, well, I'm going to ask her a question. She says, I'm confused about whether or not the presence of antibodies after infection actually confers immunity. When people get reinfected, any thoughts on how long that immunity will last?
Yeah, so again, some really excellent questions, and I'll keep falling back on my, we're just learning exponentially about this virus every day. On the reinfection issue, I think there's still a little bit of controversy, and some of it depends on how you do your diagnosis. There were certain studies where people thought they were seeing reinfection, and then it turned out that it may have been just persistence of virus, for example, in PCR for longer than we realized. Similarly, with how long immunity lasts, even if we tracked the very first person to have got COVID-19, or the first person we recognized anyway, we'd only have a timeline right now of 5 or 6 months, and that would be as long as we could say immunity lasted. So again, I think that these are not completely defined yet. We need prospective cohorts being followed. This is happening. We will continue to learn. Somebody asked about the challenge model. If a year from now we can safely do a challenge model, I think one way it could be used is to look at vaccines. Vaccines that are given now, your immunity question or your reinfection question. If you can safely use a challenge model, then we can look at people that had a vaccine 1 or 2 or 3 years ago and see if it still works. So it's going to take some time to get these answers.
Well, we have time for 1 or 2 more questions. Alex?
We have a couple here I think are good to get out. This is from Ashley Vallis, who isn't on the line with us. She's watching us on the Facebook live feed. She says, given the shortened timelines involved in finding a vaccine, should we be worried about long-term side effects when we eventually do have one available? I've seen many people worried that we are rushing this. They don't want to get the vaccine once we have one because they're too fearful.
Yeah, so again, another good question. I think we have to look at models of other diseases. The one such side effect that you may have heard talked about in the news and what's been thrown around is something that's called vaccine-enhanced illness. So generally, when you get a vaccine, it protects you when you're exposed to that pathogen. On rare occasions, with a recent dengue vaccine, with a very old measles and respiratory virus vaccine, paradoxically, when people had a vaccine and were exposed to the pathogen, they had more severe disease. Fortunately, I believe we have more sophisticated immunology now. We're certainly going to try to understand in these early volunteers, for example, the balance of good antibody, which would be neutralizing antibody, to non-neutralizing antibody. Animal models are underway and are absolutely required by the FDA to look for a vaccine-enhanced illness. And then in all of these trials, even though we hope to get a short-term fast answer, at least the ones that we're involved in designing here, we are insisting on a follow-up of at least 2 years. So if there's some waning of immunity and exposure and some immunologic phenomenon that we don't understand, that we are still following those people closely and assessing.
But you have a great example of how vaccination has cured disease. Of course, in the case of vaccinia, that disease, I've never seen a case of smallpox. Have you?
I have never seen a case of smallpox, and we know it's eradicated. There are many. I've never seen a case of polio. So yeah, it's always a risk-benefit equation. And again, during a pandemic with such a severe disease, certainly we're expecting to see benefit with these vaccines, but we absolutely cannot forget the follow-up, even long-term follow-up for risk and safety.
Alex, how about one more question? And
all right, here's Robert. Okay, here's Robert Block. Robert, are you with us? We have a lot of shy people out there, or first-timers to web.
Yeah, no, I just didn't know which button to push.
Oh, there you go. Go ahead, Robert.
Thank you, and thanks for the great talk and your great responses, both of you, Bruce and Kathy.
Thank you, Bob.
Thank you. Just following this in the newspapers and reading the occasional scientific publication, I'm really confused about how deadly this disease is. What's your best estimate of the mortality rate?
I'm not sure I'm willing to give a mortality rate because, as you've alluded to, a rate means that you have an accurate denominator, and we still do not have an accurate denominator. What we can say is that this is a very serious illness. It's certainly more serious than influenza, which is one you hear it be compared to. And one statistic that I give, which is close to home, is, we've got about 80 plus people in the hospital right now with COVID-19. A large percentage of them are on ventilators. And here's the issue. We're only getting a couple new admissions a day, but these people are sick and they stay a very long time. And so again, this is a serious disease. I can't give you a mortality rate. We know it's a serious disease. We know it's more serious in older age groups, and we're beginning to learn about the many non-pulmonary complications as well.
Thank you.
What a great hour, Dr. Neuzil. I want to thank you for these great discussions. You can see we've got a great crowd at UMB asking questions. And I know as time goes, we'll learn more about this disease, about time for you to come back, maybe in a couple of months, to update us all. So I really, really appreciate it. I want to thank all of those of you who attended virtually, and we'll look forward to next week, another face-to-face. So thank you all, and we'll see you later on. See ya.
Thank you for having me.